नहीं ये रहता है,
कनेक्शन नहीं है।
हाँ
सही बात।
नहीं, कनेक्शन नहीं है सर, उसके JRSR भी नहीं आते हैं। एनीवे सर, पूनम मैम से आप कभी भी बोल के कुछ भी जरूरत होगा तो बोल सकते हैं, उनके सर
नहीं जरूरत पड़ेगा नहीं, वो लोग अपना है, अपना कर रहे हैं, लोग करना है। मेरी डॉटर वो है जिपमर में।
ओके ओके, सो शी इज डूइंग सर,
उसने MBBS भी जिपमर से किया, शी इज डूइंग MD पैथोलॉजी इन जिपमर।
ओके सर, इट्स वेरी नाइस सर, योर लैब वर्क विल कंटिन्यू।
नहीं नहीं, वो लैब में नहीं आने वाले। अच्छा, वी आर गोइंग टू स्टार्ट, वी आर लाइव।
ओके 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 सर।
Good evening, everybody. Welcome to this evening episode of Pursue. And today we have Pursue 7E, which is neuropathology, and we are streaming live from Jodhpur via Kolkata. And with us we have Dr. Vikarn Vishwajeet, who is a postgraduate from PGI Chandigarh. He has done his BM Histopathology from PGI Chandigarh. Presently, he is an assistant professor in the Department of Pathology and Lab Medicine at AIIMS Jodhpur. He's got multiple publications in index and national and international journals, and he's an expert in neuropathology, and he will be talking today on demyelinating and neurodegenerative disorders in the central nervous system. Before I ask Dr. Vishwajeet to take over, let me request all of you to please keep your mic muted, your camera off, and please do not share your screen. With this, let me ask Dr. Vikarn Vishwajeet to take over, sir. Please start and share your screen. Thank you.
Thank you, sir.
Please present now and your entire screen. Yeah.
Yes. So a very good evening to all of you. So thank you, sir, for your kind introduction. And today we will be discussing pathology of neurodegenerative and demyelinating disorder. So first we will discuss neurodegenerative disorder, followed by demyelinating disorder. We will try to cover the major topics in these areas. So before I will start, I will put disclaimer. In this slide, various diagrams and images are included, and each diagram and images are duly cited. And I want to express my sincere gratitude to all my teachers from PGI Chandigarh. And finally, the presentation is aimed mainly for postgraduate training and is simplified with representative images.
Please share your full screen, sir. Your full screen is not seen.
Sir, it is
not yet. No.
Sir, it is visible now?
Yes, now it is visible. Correct. Yeah. Right. Please.
Sir, in this mode, I cannot use pointer, sir.
Doesn't matter. You just keep going. Keep scrolling your thing. No. But actually, your full screen is was not being seen earlier. Now we can see. Yeah, I can see your disclaimer also now. Yeah. Please go ahead. Thank you. Sorry.
So. Oh, sorry for the interruption. So neurodegenerative disorder are broad-ranging and highly complex group with varied etiology and have frequently overlapping clinical manifestations. These diseases usually present in adulthood, and most of the cases occur after 50 years of age, and mostly in 6 decades and after. And the etiology are varied. The disease is prevalent and often debilitating. It is very difficult to diagnose neurodegenerative disorder even at autopsy. So in most of the cases, biopsies are not usually done because the findings are very overlapping, and often this disease do not have a definite cure yet. So it is often not recommended to biopsy these lesions. So most of these lesions are diagnosed on autopsy studies. These diseases have unclear etiology with genetic and environmental factors implicated. So clinically, the clinical presentation in this disorder varies between and within diseases, and patient can present either as a pure form or a combination of dementia, psychiatric disturbances or movement disorders. So dementia is characterized by progressive memory impairment and global cognitive decline with aphasia, apraxia, agnosia, and loss of executive functions. Psychiatric disturbances can be seen in the form of depression, delirium, delusion, hallucination, personality and behavioral changes, while movement disorders can be in the form of weakness, ataxia, tremor, myoclonus dystonia, spasticity, rigidity, and dyskinesia. So each neurodegenerative disease has a particular predilection for a specific anatomic location, and based on that, the histological findings are correlated. In most cases, histological findings are subtle and sparsely displayed. In the commonality among all these neurodegenerative disorder is that there is abnormal deposition of intracellular and extracellular protein accompanied by progressive loss of neurons. In certain diseases like in Alzheimer's disease, we can have neuritic plaque or neurofibrillary tangles, which can be a specific, and Lewy bodies can be a specific finding in dementia with Lewy bodies. So this can be very helpful. So most common neurodegenerative disorder encountered is the Alzheimer's disease, and second most frequent is the Parkinson's disease. In this disorder, a biochemical and genetic basis has been postulated. So before proceeding further, let's have a brief classification of the neurodegenerative disorders. So neurodegenerative disorders are dominantly classified into two subtypes based on the dominant manifestation. It can either present as cognitive disturbances or movement disturbances. So among the cognitive disturbances, there can be temporoparietal degeneration, which can present with memory disturbances. And in this disorder, there is particular degeneration of the hippocampus and cortical neurons of temporal and parietal lobes. The classical disease in this category include Alzheimer's disease and dementia with Lewy bodies. The second category is frontotemporal degeneration. This disorder can present with apathy, disinhibition, depression, and memory disturbances. In this disorder, there is degeneration of frontal and temporal lobes. The classical entities included in this include Pick's disease, familial tauopathies, frontotemporal lobar degeneration with motor neuron disease, and frontotemporal lobar degeneration with ubiquitin only. Then there are multifocal degeneration with varied clinical presentation, and the classical disorder in this category includes Parkinson's disease with dementia, prion disease, and corticovascular degeneration. Next category is the movement disorder. So in movement disorder, we have akinetic rigid type of diseases in which the patient have bradykinesia and rigidity, and in this disorder there is degeneration of the substantia nigra, and the classical entities in this category is Parkinson's disease, progressive supranuclear palsy, multiple system atrophy with striatonigral degeneration, and corticovascular degeneration. Then another is hyperkinetic disorder manifested by chorioathetosis and dystonia, and it is because of the degeneration involving the basal ganglia. The classical disease is Huntington's disease and dentorubropallidoleucial atrophy. The next category in movement disorder is ataxia, which is exemplified by Friedreich ataxia, spinocerebellar degeneration, multiple system atrophy with olivopontocerebral atrophy. And then in the last, we have motor neuron disorder, where the patient present with motor weakness and there is degeneration involving the motor system. And the disorder includes amyotrophic lateral sclerosis, spinocerebellar muscular atrophy, and spinal muscular atrophy. So this is a schematic diagram depicting the main group of neurodegenerative disorders, and the upper panel you can see the genes which are characteristically involved in causation of the disease, and these genes encodes some of the genes encode certain proteins which are abnormally aggregated, and leads to the development of this disease. So six different type of proteinopathies have been described, and it includes prion protein, cellular prion protein, which is a normal protein which is abnormally folded to form PRPSC, which is a misfolded protein, and it gives rise to the prion disease. Then there is amyloid beta peptide 42, which due to cleavage by secretases can give rise to amyloid beta peptide, and it is exemplified by the Alzheimer's dementia. Then we have tauopathy, which tau is a protein encoded by the MAPT gene, and hyperphosphorylated form of tau is implicated in a number of diseases, and it can include Alzheimer's disease as well, and frontotemporal lobar degeneration disease also. Then there is TDP43 protein, which is implicated in FLT, frontotemporal lobar degeneration diseases, and then there is FUS protein. FUS is fused in sarcoma protein, and it is also implicated in some cases of frontotemporal lobar degeneration. Then there is alpha synuclein protein, which forms Lewy bodies, and Lewy bodies are seen in a number of diseases like dementia with Lewy bodies, Parkinson's disease dementia, multiple system atrophy. So these are what we have here. The majority of the non-vascular dementia fall into these six categories of neurodegenerative proteopathy, and these proteins includes amyloid beta peptide, microtubule associated protein tau, then TDP43, that is star DNA binding protein, first fused in sarcoma protein, alpha synuclein, and prion protein. So these six group of protein are involved in different neurodegenerative disorder. So in one center of London, they have done biopsy of the brain to diagnose neurodegenerative disorder, particularly those cases where the dominant presenting symptoms was dementia. In their study, they found Alzheimer's disease account for 16 cases out of total 51. Then Creutzfeldt-Jakob disease, which is a prion disease, is seen in 21 patients. Viral and paraneoplastic meningoencephalitis was noted in 5 cases. Pick's disease and frontotemporal lobar degeneration was detected in 4 cases. Vasculopathies in 4 cases, additional 4 cases, and then inflammatory condition in the form of vasculitis and neurosarcoid in additional 4 cases. Then dementia with Lewy bodies, corticobasal degeneration, and other tauopathies account for 3 cases. So before proceeding further, let's discuss how to sample brain in case of neurodegenerative disorders. So in case of neurodegenerative disorder, we need to sample the different area which can be affected. So before slicing the brain, it is important to fix the brain in formalin for at least 2 to 3 weeks, and thereafter after proper inspecting the cortical surface, it can be serially sliced, and the representative section that can be taken in case of dementia includes middle frontal gyrus, then cingulate gyrus, then superior and middle temporal gyri, then we have hippocampus and parahippocampal gyrus, then inferior parietal lobule. Then there is the sample should be taken from globus pallidus and putamen. Midbrain section should be taken, pons section should be taken, and if there is additional consideration for associated movement disorders, sample can be taken from caudate nuclei and dentate cerebellum, including the dentate nucleus and medulla. Additional section from a spinal cord needs to be taken in movement disorder as well. So this is important to know where should the sampling should be done. So once the slide has been prepared and you are looking for neurodegenerative disorders, so certain IHC are available which are very helpful in making distinction among them, and the 6 markers which are in use are phosphorylated tau protein, which is expressed in Alzheimer's disease, Pick's disease, progressive supranuclear palsy, and frontotemporal lobar degeneration. Amyloid precursor protein is used to delineate the neuritic and diffuse plaques in case of Alzheimer's disease and cerebral amyloid angiopathy. Ubiquitin marker can be used for diagnosis of dementia with Lewy body, Parkinson's disease, motor neuron disorder, multiple system atrophy, and frontotemporal lobar degeneration. Then alpha synuclein can be used to detect Lewy bodies in dementia with Lewy bodies, Parkinson's disease, and multiple system atrophy. TDP43 is expressed in FLT, frontotemporal lobar degeneration with motor neuron disease, and human prion protein can be used in a specialized laboratory for detection of prion disease. So in this class, in this presentation, we will discuss Alzheimer's disease, dementia with Lewy bodies, frontotemporal dementia, and a few points about the prion disease, and then we will move to the demyelinating disorder. So Alzheimer's disease is the most common cause of dementia in older patients, and it accounts for 50% to 90% of total neurodegenerative disorder in adults. The disease usually become clinically apparent as gradual impairment of higher cognitive function. As the disease advances, there is deficit in memory, visuospatial disorientation, judgment, personality, and language problems. This disease is typified by accumulation of amyloid beta and tau protein in a specific brain region, and this is the main proteins responsible for the pathogenesis of Alzheimer's disease. This peptide, amyloid beta peptide, aggregate readily and forms beta pleated sheets and binds congruent. So just a few lines about the pathogenesis of Alzheimer's disease. So in Alzheimer's disease, so this is normal amyloid precursor protein. In normal condition, it is cleaved by alpha secretase and gamma secretase, and this peptide which is generated is usually normal, while when the amyloid precursor protein is cleaved by beta secretase and gamma secretase, there is generation of abnormal peptide. That amyloid beta peptide is generated, and this abnormal beta peptide aggregate abnormally and leads to the formation of amyloid fibril. So once amyloid beta peptide generation occurs, it can directly damage the neurons by oxidative damage and excitotoxicity, or it can abnormally aggregate within the neurons to form neuritic and diffuse plaques, and as well as neurofibrillary tangles, which further leads to the clinical cognitive and behavioral abnormalities. So coming to the gross pathology, so grossly brain examination in these patients shows varying degree of atrophy, mainly affecting the cortical areas. Then hippocampus, amygdala, and corresponding white matter atrophy can also be noted. Due to the extensive atrophy there of both white matter as well as gray matter, there can be dilatation of the ventricles, which can lead to hydrocephalus ex vacuo. Cortical atrophy is most striking in mesotemporal areas with variable involvement of parietal and frontal lobe. And so in this picture, what you can see is there is generalized cortical atrophy with, you can see, widening of sulci and narrowing of gyri. So sulci widening and narrowed gyri. So this is a coronal slice, and here you can see there is also there is atrophy of the hippocampal area and also white matter atrophy, giving appearance of your hydrocephalus ex vacuo type appearance. So microscopic pathology in Alzheimer's disease include deposition of beta amyloid peptide in neuropil as diffuse and neuritic plaques. Then there can be formation of fibrillar polymers of hyperphosphorylated tau protein in the form of neurofibrillary tangles and neuropil threads. Additionally, there can be neuronal loss, gliosis, and cerebral amyloid angiopathy. Neuronal loss and gliosis are non-specific finding, while these amyloid plaques and neurofibrillary tangles are the relatively specific finding for Alzheimer's disease. So this is a picture of You can usually diffuse plaques are not obvious or evident on light microscopy, so silver stains and HC are often used for the diagnosis. So this is a case of uh, diffuse plaque. You can diffuse plaque and then downward source presence of this neuritic plaque. So neuritic plaque has a dense eosinophilic core surrounded by this dystrophic neurites. So this is the silver stain, and in this silver stain you can see neuritic. This denotes the neuritic plaques, and which are highlighted by the ubiquitin immunohistochemistry. So the upper diagram shows diffuse neuritic plaque, while the lower diagram shows diffuse plaques, while the lower diagram shows neuritic plaque. So neuritic plaque has a eosinophilic core which may be surrounded by dystrophic neurites. And then we have this neurofibrillary tangles. So neurofibrillary tangles in neocortical neurons can appear as a pale basophilic fibrillary inclusion in the cell bodies of neurons, and they stand with they take the shape of neurons in which they are seen. This is a silver stain, Balchowski silver stain, and then you have IHC tau protein can be used to demonstrate these neurofibrillary tangles, and this is ubiquitin immunohistochemistry to delineate the your neurofibrillary tangles. So wherever neurofibrillary tangles occur, it usually takes the shape of cell body. If it occurs in pyramidal neurons, it is usually in the form of elongated appearance, while when it occurs in a smaller neurons, round neurons, it can take the form of globose form, globoid type of form it can take. Then this is the histological picture of cerebral amyloid angiopathy, and here there is deposition of beta amyloid peptide in the wall of cortical vessels, which can also involve leptomeningeal as well. And you can see this deep eosinophilic acellular material in the wall. This is amyloid, and often there is concentric arrangement of these amyloid deposits. Sometimes the vessels can be completely occluded by the amyloid deposition. Often the endothelial cells may undergo apoptosis. In the last D figure shows in some cases amyloid deposit may be associated with multinucleated giant cell and mitotically active microglial cells. So this can be confused at times. So this is about the main histological finding. In 1991, Brack and Brack reported the topographic distribution of neurofibrillary tangles in brain of dementic patient, and they outlined a progressive appearance in 6 stages, and this progression correlated well with clinical cognitive decline. So stage 1 and 2 are the transentorhinal stage, stage 3 and 4 are limbic stages, and stage 5 and 6 are neocortical stages. So this is a very nice article where they have shown the appearance of these lesions in different stages. So in stage 1, the lesion is confined to the transentorhinal region and mainly located medial to the rhinal sulcus. In stage 2, there is extension into the entorhinal region, right, and also focal into the early hippocampal involvement can be noted. In stage 3, the entire basal surface, these two represent the stage 3, and in this the entire basal surface of temporal lobe with severe involvement of entorhinal cortex is noted, and the pathology extend into the adjacent neocortex from occipitotemporal gyrus laterally and lingual gyrus posteriorly. So you can see they are bordered by the occipitotemporal gyrus in the lateral and lingual gyrus in the posterior location. So this is in stage 3. Now in stage 4, there is severe involvement. There is severe involvement of the insular cortex, and you can see the involvement of the occipitotemporal gyrus as well. Finally, in stage 5, the lesion extends to the superior temporal gyrus. Stage 6 is identified by extension into the parastriate area, peristriate area, and primary areas of the neocortex, the straight area of the occipital neocortex. So these are the different 6 stages in which the authors have described progression. Then the histological finding can be confused with certain entities. It can be confused with age-related changes which is not associated with dementia. So in these cases, neuritic plaque and neurofibrillary tangles can be seen, but usually in age-related changes, diffuse type of plaques are noted. And the distribution and quantity is very important for differentiating it from the Alzheimer's disease. In Alzheimer's, there is the quantity is more, and there is severe involvement of cortical areas. Then it can be confused with dementia with Lewy bodies and frontotemporal lobar degeneration. So this we will discuss further. And vascular dementia is another differential in this case, where there is multiple old infarct or diffuse white matter ischemia can be noted. So coming to the next entity, that is dementia with Lewy bodies. So dementia with Lewy bodies account for 10 to 25% of neurodegenerative disorders, and it's characterized clinically by dementia associated with hallucination, fluctuation in consciousness, Parkinsonism, and sensitivity to neuroleptics. Pathologically, there is presence of Lewy bodies in cerebral cortex, basal forebrain, brainstem, and spinal cord. The patient present in their 6th decade. And gross pathology, there is less hippocampal and mesotemporal atrophy when compared to the Alzheimer's disease patient. Sometimes cortical atrophy cannot be discernible at autopsy. Substantia nigra in these cases are variably depigmented, and locus ceruleus is almost invariably affected in these cases. So just coming to the histopathology part. So two distinct type of Lewy bodies are noted. Cortical Lewy bodies. So this is the first picture on the left side of this slide is the cortical, and the right picture shows the classical Lewy bodies. So cortical Lewy bodies are subtle, difficult to identify, and measures 3 to 20 micron in diameter, and are ill-defined, round to oval, pale eosinophilic without any dense center. Classical Lewy bodies are discrete, perfectly round. So you can see in this neuron, perfectly round, eosinophilic, and occasionally concentric and laminated structure with dense core and peripheral halos. These Lewy bodies are minimally argyrophilic, and they are immunoreactive to antibody against ubiquitin and alpha-synuclein. In addition, histopathology in these cases can also show ubiquitinated Lewy neurites, which are mainly seen in hippocampus and amygdala. Spongiform changes can also be noted in mesotemporal and paralimbic cortexes. So Lewy bodies can also be noted apart from dementia with Lewy bodies in Parkinson's disease, multiple system atrophy, and Parkinson's disease dementia. So we will discuss about idiopathic Parkinson's disease. So Parkinson's disease Parkinsonism is a set of clinical symptoms characterized by triad of resting tremors, truncal rigidity, and bradykinesia. It can result from various conditions. It can be due to neurodegenerative disorder, it can be due to exposure of toxins, or can be due to chronic use of neuroleptics or head trauma. Idiopathic Parkinson's disease usually present with Parkinsonism, and the neuropathology which are seen in this disorder is classical Lewy bodies, which is mainly located in residual pigmented neurons of substantia nigra, locus ceruleus, dorsal motor nucleus of vagus, other brainstem nuclei, as well as in the basal nucleus of Maynard. Rarely, very rarely, the cortical Lewy bodies can be found in cortical areas. Neocortex usually appears normal in these cases. So this is here you can see the upper left corner of the picture shows normal substantia nigra in a control patient, and when compared to the diseased, there is significant pallor of the substantia nigra. The right corner upper part shows normal locus ceruleus pigmentation in the in these cases there is marked loss of these pigments. So examination of these areas are very important. So dementia may develop in minority of the patient with idiopathic Parkinson's disease. So development of dementia correlate with occurrence of Lewy bodies in the cortical area. So here there is some overlap with dementia with Lewy bodies and idiopathic Parkinson's disease. So when dementia occurs more than 1 year after diagnosis, it is known as idiopathic Parkinson's disease with dementia, and in this disorder the Lewy bodies are seen in cortical areas as well. While in dementia with Lewy bodies, these Lewy bodies are more widespread and severe in cortex and amygdala, and it affects brainstem relatively less compared to the Parkinson's disease. So if a patient with Parkinson's disease has Lewy bodies in cortical area, he will develop features of dementia, and in that case it will be categorized as idiopathic Parkinson's disease with dementia based on the clinical course of the disease. So coming to the next part, that is frontotemporal lobar degeneration. Frontotemporal lobar degeneration is a heterogeneous group of disease and which is characterized by disturbances of behavior and personality. There is different type of language impairment with or without motor neuron disease or Parkinsonism. So characteristically there is atrophy of the frontal and anterior temporal brain lobes, and it is molecularly defined based on the presence of different inclusions, derived different proteins which are involved. So in 2010 major molecular class of frontotemporal lobar degeneration have been given, and it includes six categories. So FLTD tau, FLTD TDP, FLTD UPS, FLTD FUS, and FLTD NI. So tau, FLTD tau is the disease implicated in this category includes Pick's disease, corticobasal degeneration, progressive supranuclear palsy, azyrophilic grain disease, and then we have white matter tauopathy with dementia, and then there is NFT dementia. Then there is white matter tauopathy with globular glare inclusions. Then the next category is FLTD TDP, and in this category type 1 to 4 are given, and then their next category is FL frontotemporal lobar degeneration ubiquitin proteasome system. So in this category frontotemporal dementia linked to chromosome 3 is included. Then frontotemporal lobar degeneration with fused in sarcoma, and it includes atypical frontotemporal lobar degeneration, then NIFID, which is neuronal intermediate filament inclusion disease, and then BIBD. BIBD is basophilic inclusion body disease. So this is the molecular classification of different disease which is included in the frontotemporal lobar degeneration. FLTD NI indicates no inclusion. So coming to molecular group, FLTD tau. So tau protein is encoded by the MAP2 gene, and it helps in the stabilization of the axonal microtubules. And in pathological condition, it becomes aberrantly hyperphosphorylated, dissociate from microtubules on forms aggregate within neurons and glia. Electrophoretically, 6 different isoforms have been described, and phosphorylated 3R isoforms is implicated in Pick's disease, while the 4R isoforms are implicated in progressive supranuclear palsy and corticobasal degeneration. In Alzheimer's disease, both 3R and 4R tauopathy is involved. Coming to the next, FLTD-TDP. So this is the most common subgroup, and it is associated with TAR DNA binding protein 43, which is involved in transcription repression. In this, the inclusion which is seen is ubiquitin positive, tau and alpha synuclein negative. Then we have FLTD, ubiquitin proteasome system. Here the neuronal inclusion are characterized by positivity by ubiquitin and P62 positivity. Tau, TDP43 and FUSH are negative in these cases. Then we have frontotemporal lobar degeneration with FUS, that is fused in sarcoma group, and in this the inclusions are positive for ubiquitin but they are negative for tau and TDP. They harbor FUS first gene mutation, and the disease which are included are BIBD, basophilic inclusion body disease, and frontotemporal lobar degeneration with intermediate filaments. So this is about the molecular classification of frontotemporal lobar degeneration. Now the Pick's disease is a common within the frontotemporal lobar degeneration, and here you can see the characteristic atrophy of the frontal and the temporal lobe. So you can see the characteristic atrophy of the frontal and temporal lobe, and on coronal slicing you have atrophy of the hippocampal areas and temporal areas. So in this, the microscopic picture shows presence of this Levy, these Pick cells. Pick cells are nothing but they are ballooned. They are balloon cells with achromatic cytoplasm and have an eccentric nucleus. So upper left picture shows presence of Pick cells, while the upper right picture shows presence of Pick's bodies. So Pick's bodies is a slightly basophilic appearance, and they can be seen in pyramidal cells of the cortical neurons and in or in the dentate cells of the hippocampus. So this is the silver stain which highlights these Pick's bodies, and this is your tau immunohistochemical stain, and which highlights the Levy bodies in these cells. So coming to the next part, that is prion disease. Prion disease is a very rare condition, and it is due to abnormal forms of a cellular protein. It is a rapid progressive course, and the human prion disease include Creutzfeldt-Jakob disease, Gerstmann-Schnecker disease syndrome, and fatal familial insomnia. While disease like scrappy, chronic wasting disease, bovine spongiform encephalopathy, they are described in animals. So coming to the pathogenesis of a few points about the pathogenesis of the prion disease. So in prion disease, cellular prion protein have an alpha helical structure, which can sometimes form beta sheet PRPSC in arrangement. So this conformation change can occur either from exogenous sources such as contaminated food or medicines, and once the PRPSC is generated, it converts additional molecules of cellular prion protein into PRPSC, and these become aggregated, and ultimately it leads to formation of aggregates. So on histopathology, we can see there is a spongiform changes in the cerebral cortex, and inside you can see neurons with cytoplasmic vacuoles, and the second picture in the middle and right corner shows plaques, cortical plaques surrounded by the spongiform areas. So this is Kuru plaques in cerebellum, and this is a cortical plaques with associated spongiform changes. So this is case of prion disease. So coming to the next part of the presentation, demyelinating disorder. So demyelinating disorders are acquired idiopathic disorders which are characterized by the myelin loss and occurs on a background of inflammation. The most important point is that there should be preservations of neurons, preservation of axons, which can be highlighted by neurofilament, immunohistochemistry, or by silver impregnation methods. Diagnosis is usually based on complete clinical history and neurological examination. CSF fluid, neuroimaging, and neurophysiological findings are very helpful. Biopsies are usually performed in these cases to exclude treatable disease, and sometimes the demyelinating disorders can be confused with neoplastic entities as well. So, in a case of demyelinating disorder, several special stain and immunostains are very helpful. So, on normal routine hematoxin and eosin stain, uh, it the demyelinating lesion can show hypercellularity, vacuolization, and presence of numerous perivascular and parenchymal macrophages. Myelin stain is used to demonstrate the demyelination, depending on whether it is sharp or sharply demarcated or irregular margins. The lesions of multiple sclerosis can be classified. Then we have axon staining for axons. So it can be done by silver impregnation methods, and in this acute axonal injury can be demonstrated particularly in FACT cases where there is loss of axons as well as myelin. Then if there is consideration of infectious pathology, special stains like grams, acid fast bacilli or fungal stains can be performed. IL rate O can be useful to demonstrate lipid in macrophages if one is suspecting fat embolism. The glial fibrillary acid acidic protein is used to demonstrate astrocytosis in a case of chronic demyelinating lesion. CD4, CD8 and CD20 used to highlight the lymphocyte subsets. Macrophage markers are very important, and if someone is suspecting progressive multifocal leukoencephalopathy type of lesion, so one should preserve fresh tissue for further studies, and electron microscopy can also be done, and if tissue can be preserved, it is very good to confirm the diagnosis to demonstrate the viral particle in case of PMA. So coming to multiple sclerosis is a chronic disabling demyelinating lesion of unknown etiology. It is most common cause of non-traumatic disability in young adult. Approximately 50% of MS patients become dependent on walking aids, and by end of 15 years, many requires wheelchair. So the pathologic hallmark is that this lesion shows area of focal demyelination, which is characterized by variable gliosis, inflammation, and with relative axonal preservations. Lesions are usually disseminated throughout the CNS but have a particular predilection for optic nerve, subspinal cord, brainstem, cerebellum, and periventricular white matter regions. So coming to the pathogenesis of multiple sclerosis. So different cell types have a role in the pathogenesis of multiple sclerosis. So initially what happens, the T cell express alpha for beta 1 integrin, and they bind to the ligands which are expressed on the endothelial cells. So VCAM1 and osteopontin. So vascular cell adhesion molecule 1 and osteopontin are expressed on the endothelial cell. These T cell bind to them and then undergo diapedesis and traverse the perivascular cuff and enter the extracellular matrix before gaining entrance into the cerebral central nervous system. Inside the brain, the antigen presenting cells they present myelin fragments to these T cells, and these T cells then antigen presenting cells in combination with these T cells secretes cytokines, osteopontin, and other molecules, and which causes damage to the myelin sheath. In addition, there is production of antibodies by the plasma cells as well. So the plasma cells produce antibodies which further damage the myelin sheaths. So this is the pathogenesis of multiple sclerosis. So grossly, the acute lesions are poorly demarcated, soft, with white to pinkish yellow, while the long-standing chronic plaques are distinctly formed, slightly retracted, and have a brownish discoloration. MS lesion usually evolve differently during early versus chronic disease phases, and within each phase, different types and stages of demyelinating activity are evident. So this is a gross picture of of multiple sclerosis. So you can see in there is in cases of chronic plaques there are sharp borders, as can be seen in superior frontal and temporal lobe, while recent plaques in corpus callosal area and adjacent to the claustrum. So these areas are paler and have indistinct and ragged borders. So different type of plaques have been described depending on the presence and distribution of myelin-laden macrophages. So different stains which are helpful for classifying these are Luxel fast blue PS, Balchowski silver impregnation, CD68 and neurofilament protein. Acute active plaques are characterized by hypercellular demyelinating lesions with relative axonal preservations. There is massive infiltration by myelin-laden macrophages that are evenly distributed throughout the lesion. Also, there is variable loss of oligodendrocytes, and there is profound perivascular and parenchymal infiltrate composed mainly of T cells. In addition, there can be reactive astrocytes as well. And so next, this is a histological picture of your active lesion of multiple sclerosis. So you can see a highly cellular lesion which is chiefly comprises of the perivascular macrophages and lymphocytes along with some astrocyte proliferation. And this is the Luxel fast blue PS stain in the upper right corner of the picture, and it shows relatively sharp demarcation, although not as sharp as in chronic lesion, and higher magnification shows presence of these macrophages with engulfed myelin in the cytoplasm. In active cases, the myelin stain blue in the cytoplasm of these macrophages. And then this is the CD68 immunostain, which highlights the collection of macrophages in these areas. An important finding in multiple sclerosis, there is relative preservations of axons despite the loss of myelin. There is preservation of the axons, which is shown here by the silver Balchowski stain. Then coming to the chronic active plaques. Chronic active plaques are the demyelinated lesion with relative axonal preservation and have a sharply defined margins. Here there are myelin-laden macrophages which accumulate centrifugally and expanding the plaque at the edges and diminish towards its hypocellular diminish towards it. It is hypocellular, inactive and densely gliatic center. So it has the lesion is expanding centrifugally, and while in the center there is tensely gliatic scar. Smoldering demyelinating plaques are characterized by inactive center surrounded by a rim of activated macrophages and microglia, few of which contain myelin degradation product. Inactive plaques are completely demyelinated lesions characterized by extensive loss of axons and oligodendrocytes, extrogliosis, and relatively less infiltration of macrophages and lymphocytes. Shadow plaques represent remyelinating lesions, and they are sharply circumscribed lesions of reduced but not absent myelin staining. So acute and chronic active plaques are more commonly found in fulminant or early multiple sclerosis cases as well as in secondary progressive cases, while smoldering and inactive plaques predominant in patients with primary progressive or secondary progressive multiple sclerosis. So this is a histological picture of a chronic inactive scar of multiple sclerosis. So here you can see intact white matter in the left side of each microphotograph, while on the right side there is pallor and myelin loss as demonstrated by the Luxel fast blue PS staining, and also in the same stained picture you can see presence of numerous corpora amylaceae, which is provide evidence for ongoing reactive astrogliosis as well. So in this, so there is relative preservation of the axons as you can see here, while this is immunohistochemistry against the myelin proteolipid protein, and here you can see the loss of myelin in the right half of this microphotograph. Into the next, Ballot's concentric sclerosis is a rare variant of multiple sclerosis, and it gives a characteristic large concentric lesion in the CNS. The center of the lesion is oldest, whereas the peripheral rim of demyelination are recent. Here the band of preserved myelin are narrower than demyelinated band, and their inner margin are sharp, while the outer margin are ill-defined. In the so usually these patients have an acute onset, and age can range from 20 to 50 years of age. There is a steady progression. The clinical spectrum can range from steady progression to major disability, and death can occur. So this is a classical picture of a concentric concentric sclerosis, and this is immunostain for proteolipid protein. Proteolipid protein is a marker of myelin, mainly in the cases which are the staining can be seen in those cases which are late, right? So there are certain myelin proteins which are expressed early demyelination, which are lost early in demyelination, and some are lost late in demyelination. So the early myelin proteins which are lost in demyelination are MAG proteins, while PLP, proteolipid protein, is usually lost in late stages of demyelination. So this is a proteolipid protein immunohistochemistry. So higher magnification shows the relatively preserved area and adjacent lost area, and this is myelin associated glycoprotein MAG immunohistochemistry, which shows loss of myelin. So coming to the next is acute tubefactive form of multiple sclerosis. So some cases of multiple sclerosis can be mimicked as a masked lesion, and it is this lesion which are most likely to undergo biopsy. And even on biopsy, these lesions, because of their increased cellularity, they can be confused for malignancy. But if you are suspecting demyelinating disorder, you can go for a special stain for myelin, exons, and for immunohistochemical stain for macrophages. You can reach diagnosis. If there is difficulty in frozen section, touch preparation are very helpful in these cases, because touch preparations help in identification of these foamy macrophages. While in crust smear, they cannot be readily appreciated. So this is a case of tubefactive form of multiple sclerosis. So in this, you can see the lesion is highly cellular, and it appears like a malignancy. Right. So often the nuclei in this condition is pleomorphic here, while the touch preparation in this case characteristically shows the presence of this foamy macrophages along with scattered RBCs in the background. So you can see these macrophages are well demonstrated on the touch preparation on frozen sections. This is the bottom picture shows Luxel fast blue PSA stain, which demonstrate the demyelinating age of the lesion. So to avoid misdiagnosing these lesions as malignancy, always bear in mind the possibility of demyelination. Review the clinical, radiological and laboratory finding with the clinician when you are dealing with such lesions. Ask for a stain for myelin, exons, and also for macrophages. So in this way you can be able to differentiate the tumefactive lesion of multiple sclerosis from gliomas. So one important differential diagnosis for demyelinating lesion is a stroke. So in fact, what happens, there is loss of both myelin as well as exons. So the bottom picture shows silver preparation, Balchowski stain. So you can see loss of exons in the along with myelin. The loss of myelin is appreciated in the upper right corner of the picture, while the loss of exons is appreciated here in the in bottom picture. So this is a case of infarct. This is not a case of multiple sclerosis. However, correlation should be always be done with clinical and radiological findings. So coming to the next group of demyelinating disorder, neuromyelitis optica. So initially, because of its demyelinative appearance and occasional areas of hemispheric myelin damage, it has been considered as a form of multiple sclerosis. But recent work have demonstrated that immune attack in these cases is not directed against myelin or oligodendroglial component, but rather it is directed against the aquaporin 4 water channel. So, this disease is seen in adults and has a particularly prediction for women and Asian ethnicity. So, the main neuropathological finding consists of combination of markedly marked necrotizing myelopathy involving optic nerves and longitudinally extensive myelitis. In neuromyelitis optica, there is immune attack directed against the astrocytic water channel protein aquaporin 4. Clinically, the patient presents with decreased visual acuity, loss of visual fields accompanied by sensory loss, weakness, problems with bladder and bowel control. So, a few points about the pathogenesis. So, aquaporin 4 peptide are recognized by the T cells, which then are polarized to helper T subtype 17 phenotype, and they provide help to the B cells. It represents an acute destructive lesion in which there is perivascular demyelination, vascular necrosis, and superimposed white matter ischemic lesions. It has abrupt onset with fever, seizures, and had a fatal outcome in most of the upper respiratory tract infection, and it may follow exposure to a variety of drugs, viral examptions, or immunization. So, on histopathology, you can see characteristic myelin pallor, hemorrhage, and vascular necrosis. So, here you can see the vascular necrosis around the vessels, perivascular necrosis and myelin loss. Then you can have this you can have axonal asperates because these lesions often have prominent axonopathy. So next entity is progressive multifocal leukoencephalopathy. It is a disease of immunosuppressed patient in which infections of oligodendroglioma occur by the JC virus. It results in widespread demyelination and occasionally cavitation of the white matter. The predisposed individuals are mainly immunocompromised adults and often seen in the setting of human immunodeficiency virus infections. Often chronic infections, inflammatory lesions, and iatrogenic immunosuppressions can lead to development of these lesions. So in this picture, you can see multiple patches of myelin loss. Inflammatory cells are relatively sparse in these cases. Luxal fast fluorescein highlights the patches of myelin loss. Numerous enlarged plum-colored oligodendroglial nuclei are seen, and you can see the margination of chromatin in these cases. On ultrastructure examination, these viruses appears as stick and ball pattern, so it can be helpful in the diagnosis. So a few points about the leukodystrophy. So leukodystrophies are demyelinating diseases, and here there is abnormality in the formation of myelin rather than a process in which normal myelin is damaged. So till now, whatever we have seen, the myelin is damaged, but in this disease there is abnormality in the formation of myelin. Leukodystrophy are mainly seen in children's, and it is due to lysosomal and paroxysmal enzyme defect. It can involve both the central nervous system as well as the peripheral nervous system. Disease is usually progressive and result in death at an early age. So the main type of leukodystrophy are the Krebs disease, which is due to deficiency of galactocerebrosidase. Another is metachromatic leukodystrophy. Metachromatic leukodystrophy is due to deficiency of aryl sulfatase A, and the other type of adrenoleukodystrophy includes Canavan disease, Pelizaeus-Merzbacher disease. So what happens in this disease? Sulfatides are produced, but they are not degraded by the oligodendroglial cells and Schwann cells. So because of that, they mm, they get accumulated within the macrophages. So in this microscopic picture, this is a you can see large number of macrophages containing numerous granules of sulfatide. This is a Luxel fast loop pH system, and on ultrastructural appearance, there is prismatic or tuff stone type of inclusions are noted within the cytoplasm of macrophages. So other demyelinating disorders include subacute sclerosing panencephalitis, which can follow infections after measles. Then there is HIV leukoencephalopathy and vacuolar myelopathy, which reflect myelopathic process with several patterns in which HIV virus damage the white matter. Then there is Binswanger encephalopathy, which is also known as subcortical arteriosclerotic encephalopathy. It is an ischemic process in which microvasculopathies accompanies diffuse white matter damage, and dementia is often observed. Then there are CADASIL. CADASIL is cerebral autosomal dominant arteriopathy with subcortical infarct and leukoencephalopathy. In this, the white matter shows myelin pallor, cystic tissue loss, and vasculopathy. The vasculopathy is the dominant feature and is characterized by the granular degeneration of the arterial cell wall, and PS positive materials can be seen in their walls. Then there is fat embolism. So fat embolism, if severe, it can lead to catastrophic neurological deterioration. The systemic liberation of fat particles can result in embolic occlusions of a small vessels, hemorrhage, and ischemic damage. Then there is osmotic demyelination syndrome. This disorder is typically seen in pons, but can be seen in other sites as well. It usually result from the rapid correction of hyponatremia. So with this, I conclude my presentation.
Thank you so much, Dr. Vishwajeet. Excellent presentation. Very tough subject, but you have made it so lucid and so clear. Thank you so much for your effort. Thank you so much.
Thank you, sir. Thank you, sir. Thank you, sir.
Okay. Bye bye. Take care. Bye.
Bye. Bye.